Dr. Barnes here, part two of the antipsychotic lecture. This is where we go a little bit further. It gets a little bit more complicated, so buckle up. So we're going to go into side effects and another set of receptors, another system called prolactin. Let's start there. The biggest and most important thing to understand about the prolactin system as it relates to antipsychotics is that dopamine in normal physiology has another name, and that name is called prolactin inhibiting hormone or prolactin inhibiting factor. I just really need everybody to understand this, that dopamine literally equals prolactin inhibiting hormone. Meaning in normal physiology, the reason folks are not lactating, etc., from prolactin is that their dopamine is actually inhibiting it. Now, what did we say about all of these antipsychotics except for three? We said that they all block dopamine. So if you're blocking the prolactin inhibiting hormone, dopamine, then you're inhibiting the inhibitor and you get an increase in prolactin. So I need you to understand that a side effect of these medications is increase in prolactin and everything that comes with that. The most common early symptom is amenorrhea in females and impotence in men. Later you can get galactorrhea. So if you understand that, then we can go into a clinical scenario where this becomes very relevant. It's very important to understand that sometimes you can start an antipsychotic, let's say risperidone, which if you guys remember is a done, which means it's a stronger D2 receptor. Which means it would block dopamine stronger, which would further increase prolactin. So if you do a blood test and somebody has prolactin and then you realize you have to take them off of the medication, you take off the medicine, you wait until the medicine is out of the system, you repeat the prolactin level and you realize it went up further even though there's no more of the medicine in their body. And they want clinicians to understand what the next step in management here, and you may be surprised to know that it's actually a scan of the brain. Because if you start an antipsychotic and prolactin goes up, you remove it, and prolactin continues to go up, it wasn't the antipsychotic that did that, and it could be that you have a prolactinoma on your hands. So you would have to do an MRI without contrast, potentially a CAT scan, something like that. You could tell the radiologist what you're looking for, and you can try to rule out a prolactinoma. Prolactinomas are most likely microadenomas, so you actually would not get the visual disturbances until later when it becomes a macroadenoma. Then you can get bilateral hemianopia, but the amenorrhea and the impotence would be the early symptoms. Hope you guys got all that. Now, if you remember, they all block D2 except for the three. So what I just told you about prolactin will not apply to these three because these are partial dopamine agonists, which means dopamine will partially be increased. So if you remember that, then you know that dopamine will start inhibiting prolactin. So these three have a net decrease in prolactin, and that is very important to understand. Moving on. We need to talk about what happens when you block D2 receptors further. Remember, I said you get something called EPS, and the first one we're going to talk about is an acute dystonia. Oh, it's so cute. Acute dystonia. You could read that. And the take-home point here is that there is an inverse relationship between dopamine and acetylcholine, believe it or not. If you guys remember, acetylcholine does a lot of things. And one of the things it does, it goes to the neuromuscular junction, it connects to sarcomeres through calcium coupling, and long story short, it causes muscle contractions. So this acute dystonia means certain muscles will contract in the body. It can happen in any muscle group, guys. I need you to understand this, any muscle group. But for some reason, it tends to happen from the muscles from the neck up. So if you remember the sternocleidomastoid muscles, the largest nut muscle in the neck, and if that contracts, you'll actually get something called torticollis. Okay, the masseter muscle, if that contracts, it actually, you may think, is this tetanus or something similar? It is not. It is actually a dystonic reaction of the masseter muscle. The hypoglossal muscle in the mouth, if that contracts, the tongue moves, it actually sticks out a bit, and you may think that, or the patient may think that they have an allergic reaction, but it's not. It's actually a dystonic reaction of the tongue. Moving up, the eye muscles, there's the rectuses and the obliques, and their eyes can start moving in directions that are involuntary and that they didn't anticipate, and that's called an oculogyrocrisis. Okay, and these are things that unfortunately we see. So if you understand that these dystonic reactions are from an inverse relationship between dopamine and acetylcholine, then you could understand the treatment, because you need less acetylcholine, you need an anti-acetylcholine, you need an anticholine, you need an anticholinergic. The most inexpensive, readily available anticholinergic in America at least, is Benadryl diphenhydramine. So very often that's going to be the treatment for dystonia, is Benadryl diphenhydramine. Other options are benstropine, also called Cogentin, and trihexyphenidyl, called Artane. So that's EPS dystonia and acute dystonia. Okay? Very important to understand. Moving on. Another type of EPS is Parkinsonism. Parkinsonism. If you guys recall, quick refresher, regular Parkinson's disorder is when the substantia nigra in the midbrain, which is a part of the brainstem, is injured and not producing dopamine. That's not what's happening here. This is a medication-induced Parkinson's that is actually reversible if the medicine is removed. So remember, regular Parkinson's disease is low dopamine because of that, but this is low dopamine because we're blocking the receptor. So we essentially get the same symptoms of Parkinson's disease, unfortunately, when these medications are used at too high doses or inappropriate. So let's go over that. They get stiffness, cogwheel rigidity, means the muscles will move in sections. They can get a flat face. They get a pill rolling tremor, which is sort of like a movement of the forefinger around the around the middle finger and pointer fingers like this, and it is a resting tremor, meaning at rest it kind of shakes the hand, but when they go to touch something it goes away. The shuffling gait actually has more to do with the legs than, the arms than the legs. So yes, they will be slouched over and take shuffling small steps, but the thing to remember is that they don't move their arms. So if you see somebody slouch and they're actually moving their arms, that's kind of like a normal gait. But if their arms stay rigid while they're moving, that's a what we call a shuffling gait. So keep that in mind. That is Parkinsonism. That would be treated by lowering the dose or changing the medication. You could also use benztropine. You would not use the treatments that you use for Parkinson's disease like Sinemet, carbidopa, levodopa. That's a no-no. You would not do that. Moving on. Hope you guys are following me and you're having fun so far. Akathisia. If you guys made it this far, congratulations, by the way. Akathisia, this is a motor restlessness. This is like an ants in the pants. Sometimes you see it and the person cannot stop moving. Sometimes they'll just describe feeling restless inside. This is not a sustainable side effect. It should be treated, or the dose should be lowered or changed. The treatment for this restless kind of feeling is beta blockers, specifically propranolol. Okay, it's a non-selective beta blocker, which is really the only beta blocker we use in psychiatry. Moving on, tardive dyskinesia, TD, tardive dyskinesia. Tardive from the Latin word tardi, which means late. This is generally a later side effect, okay? It happens from chronically blocking the D2 receptor. And what happens is when you chronically block the D2 receptor, the receptor thinks it doesn't, the neuron thinks it doesn't have enough dopamine receptors. It creates more. We call that upregulation. The moment upregulation happens, tardive happens. If anybody knows more about how that mechanism works, I'd be happy to hear about it in the comments. Really fascinating area. And tardive dyskinesia, what is it? It is a involuntary, potentially permanent movement of the lips, mouth, tongue area, but can also happen in different parts of the body. So it would look something like this. Almost just looks as if the person is doing it voluntarily, but it's not, it's an involuntary movement. So in line with the other EPS movement problems. So this is called tardive dyskinesia. There are actually 2 FDA-approved medications out now that treat that. So that's tardive dyskinesia. The worst one, which I'm gonna maybe make a separate video about, but I'll just talk about it briefly here, is called neuroleptic malignant syndrome, or NMS. NMS. This is the worst one out of all of them, which I have a mnemonic to follow. Congratulations for making it this far.